afternoon or evening, and thank you for joining us today. My name is Susan Evans, and I am honored to welcome you to today's webinar for an enlightening discussion with Dr. Armen Moughamian to explore new diagnostics, p-tau 217, as well as anti-amyloid treatment with lecanemab and donanemab for Alzheimer's. Dr. Moughamian is committed to making a difference for those walking an Alzheimer's journey. And I see that you have joined us. I'm so glad you're here. And I must tell the audience, I am so excited that you all have this opportunity to hear from what I would consider one of the experts in the field. I was so impressed with him and his community of people he works with, that they are completely committed to helping those that have mild cognitive impairment that can be assisted with some of these new treatments. It's so exciting. And thank you so much to Kensington for supporting these educational events. As you all know, or some of you know, my father lived at Kensington for almost 7 years. He had Alzheimer's for almost 10. And so I thank Kensington every day for really helping not only my father, but also my mother and my family in helping us through that journey. And I'm so excited that you're going to hear from one of the best in the world on this today. And please, please, this webinar is for you. Please utilize the Q&A function to submit questions. And with that, join me in welcoming one of my favorite people in the world.
Wow, you're really teeing this up pretty high, Susan. It's I appreciate it, but I hope I can live up to the hype. Sorry, I was a few minutes late. I was finishing up a visit. Susan, thank you very much for inviting me. I'm very happy to talk today. And you're right. I'm very passionate about finding ways to treat patients and help people through this journey. Yeah. Well, thank you for hosting Kensington. I will share my screen and I will echo, I really want this to be for everybody. So ask me questions and, it's hard to make it interactive, but definitely write down your questions and I want to answer them as I can.
And also today, folks, we always get a lot in the Q&A, like, could you repeat that or what? A copy of today's webinar will be sent to your inbox. So I just want everyone to know that it'll be sent to your inbox. And one more thing about my relationship with you is when I cold called you, I literally called you and said, I want to do these educational events. People need to know. And you said, I'll drop everything. People need to know what mild cognitive impairment is and how these drugs can help them. Because, and I know you're going to talk about that today, but I really want to thank you from the bottom of my heart. And when I was in his office, he had a bike in there. And I said, do you ride your bike in downtown San Francisco? He said, yes. I said, does your wife know? And he said, I'm very safe. I'm very safe. And he had all the safety equipment. So thank you. Thank you. Thank you. And I'll
So my
see
bike is
you.
still here and I'm still safe, doing well. So let me introduce myself a little bit more, what I do. So my name's Armen Moughamian. I'm a neurologist by training, and I specialize in diseases of the brain that affect memory and thinking. And I really want to talk a lot about new therapies for Alzheimer's disease because, as Susan said, there is one of the main messages is I think there was always something to do in cognitive impairment, and there remains something always to do. But there's been significant advances that really are allowing us to modify this disease and slow it down, keeping people in an earlier stage longer. And I may say this again, but I say this all the time, right? I think our job as physicians is not to get people onto medications, but to really open the door so that people understand what are their options in different diseases and different stages of the disease. So happy to be here and happy to chat. I want to talk a little bit about what is Alzheimer's disease. Then I'll get into some of these therapies. I'll touch briefly on some of the trials that we're doing in the Dolby Center because I think we're making some effort, some impact, but we can do even better. And so that's I think where the current state of research is. And then another thing to emphasize is that it's not just about medications, but there's a lot of lifestyle interventions that can be implemented that can improve the quality of life of patients, but also thinking about the non-impaired individuals. How do you reduce your risk of cognitive impairment in the future. So I'll try to touch on all of this in a brief time and then leave some questions. So I said I'm a cognitive neurologist. I should probably just start by defining what is cognition. Majority of people walk into my clinic and say I have a memory problem, and we use memory and cognition kind of synonymously, but they're not. When I say memory, I think about the learning and retention of new information over time. There's a long-term memory and short-term memory, but there's a lot of other functions that the brain does. So it's attention, concentration, multitasking, navigating in space, knowing where your body is in relation to other objects around you. I would also argue that mood and behavior are a neurologic function, often sort of taken over by psychiatry. But changes in behavior and personality are often some of the earliest signs of an underlying degenerative process, particularly when it happens in older adults. So the person that all of a sudden becomes anxious at age 60 or 70, it can be a harbinger of a degenerative disease such as Alzheimer's disease. The other main thing, we have about a quarter of our brain right on the left frontal part of your brain controls language. So language is a huge component of what our brain does, and changes in language can certainly point towards the brain. And changes in any of these can actually be the onset of a degenerative disease. And there's different forms of Alzheimer's disease that can impact different cognitive domains. People always ask, well, when should I be concerned? This actually comes from the Alzheimer's Association, sort of the 10 warning signs. I would say, we don't know what normal aging is. I always put that in quotes. Certainly some of the least concerning symptoms that are most common as people get older, forgetting names, people and streets, the actor from a certain movie, you can't remember it, or you can't remember the name of the movie. That is sort of on the lowest end of concern. Misplacing something, but then being able to find it really easily by retracing your steps, pretty low concern. But when you start to have more significant symptoms that are here written on the right, where you're getting more disruptions in your daily life, trouble planning, trouble problem solving, those changes in mood and personality, that's really elevating the concern, and something that you should really talk to your primary care about and get an evaluation for. One of the other important things that we can do is, we now have tools to diagnose this disease at the earliest stages, but implied in that is that we also have the tools to tell you don't have the disease. And so I think the earlier we can intervene, we can also give a lot of reassurance by some of the negative testing. So when people come in with cognitive changes, we stage the disease based on the severity of the symptoms, but also the impact that it has on someone's life. And so diseases like Alzheimer's disease and other neurodegenerative diseases are due to the abnormal accumulation of proteins in the brain. So that starts, and then as that develops, people develop some symptoms, maybe in what we define as mild cognitive impairment. If people have symptoms of cognitive change, we can measure it on some pen and paper tests, but they are able to adapt around these symptoms. There is no functional impact. I sort of call that the annoying symptom, the memory symptoms that are annoying, but you're adapting. When people get into the dementia stage, now they have cognitive symptoms that have impacted their function. So that in the mild stages, it's instrumental activities of daily living, such as management of medications, finances, driving. And then in the moderate and severe stages, it is a prompting and dependence on simpler daily tasks. When we talk about early symptomatic Alzheimer's disease, we talk about the mild cognitive impairment stage to the early mild dementia stage. In the later stage disease, that's the moderate to severe stages. The reason I'm highlighting this now is that these new medications are really indicated for mild cognitive impairment to early stage mild dementia. And so that's why we want to be focusing on these earlier diagnoses. And I'll get a little bit into the trials around preclinical disease, because I think this is an exciting area of future development in Alzheimer's disease. I put this arrow here all the time because mild cognitive impairment is very mild and very subtle. Often families are like, they're doing fine, because they are, doesn't mean they don't have the symptoms. So it is super subtle. If it's apparent that somebody has a problem by talking to them for 5 minutes, it's probably not mild cognitive impairment. It's probably a later stage of disease. And then you have to think about, okay, so that's the stage of the cognitive impairment. Then we figure out the cause. And so a lot of this is where I come in, is figuring out, is this Alzheimer's disease? Is this a different strokes, vascular disease, frontotemporal dementia, progressive aphasia, etc.? And so that's really the point of an evaluation, is to understand the cause. So what is Alzheimer's disease? Alzheimer's disease is the accumulation of abnormal proteins in the brain. There are two. This is a curve that's kind of famous in our field called the Jack curve, that describes the temporal development of these pathologies, these abnormal proteins. So in the earliest stages, people develop amyloid in the brain, this amyloid beta. It starts to clump up in the brain. Then that leads to the second protein that accumulates called tau. This accumulates in the brain, leading to changes in brain function, degeneration, so shrinkage of parts of the brain, and then the clinical symptoms of mild cognitive impairment. And as those functional declines happen, you get into the dementia stages later on. I like this curve a lot because it has this green area, which is what it's trying to imply there is the modifiable factors, that people can build up what we call a cognitive reserve, where despite the same amount of pathology in the brain, right here, let's take this point here, they have the same amount of amyloid, they have the same amount of tau, but some patients might be mildly, more moderately affected, and some might barely have symptoms. And so this is really where those lifestyle interventions come in to reduce the burden of the disease on the symptoms. And so building that cognitive reserve through non-medicine ways is really important. So let's talk about the diagnosis of Alzheimer's disease. Currently you have to have some symptoms of cognitive change. You should have some objective measures of cognitive change over time. It is often a very slowly progressive disease, but for the past 100 years, we've been diagnosing it as a diagnosis of exclusion. What does that mean? That means that we evaluate somebody, you sort of say, it looks like Alzheimer's disease, it feels like Alzheimer's disease. We may do some tests, lab tests, and an MRI. It doesn't look like it's something else, so you've excluded everything else, so it probably is Alzheimer's disease. That's the diagnosis of exclusion. It was not very exact. It was pretty good, but it wasn't perfect. And so what we've needed are tests that can actually switch this from a diagnosis of exclusion, meaning something we rule everything else and therefore it's probably Alzheimer's disease, to a diagnosis of inclusion, meaning a confirmatory test for Alzheimer's disease. And we now have that. We actually have a couple of different ways to do this. Most useful in the earliest stages where there's more uncertainty about the cause. And so really in that mild cognitive impairment to mild dementia stage is when we think about using these biomarkers, which are biological markers of the disease, a way to prove that people actually have this underlying pathology in the brain. And it increases our confidence in the diagnosis and helps us understand in those earliest stages of the disease. There are three available types of biomarkers that we have, primarily really looking at amyloid pathology in the brain. These are the ones that are clinically available. There are some research trials using tau PET, for example. So the field is moving forward, but these are really the ones that are clinically available at this time. The first is an amyloid PET scan. So this is an imaging way to measure the level of amyloid in the brain. We inject people with a dye that binds to amyloid, and then we put people in a scanner that detects this dye, and we can get a certain pattern that shows that there's abnormal amyloid in the brain versus a negative pattern that shows that there isn't that abnormal amyloid in the brain. It's a very good test. It's sort of probably I would say actually the lumbar puncture and the amyloid PET are both very, very good at detecting this. I would say more patients prefer doing an imaging test than the spinal fluid analysis. So that's the second one on here, is a lumbar puncture. Has a bad name. Everyone doesn't like doing it. It's not that big of a deal. I do them here in the office all the time. And what we're doing is collecting spinal fluid, which bathes the brain, and then measuring the levels of this abnormal amyloid in the brain, as well as levels of abnormal tau in the brain. And this is also a very sensitive measure to detecting this early Alzheimer's pathology. it is more invasive because a needle has, it involves doing a spinal tap, which is very similar to an epidural that women will get with childbirth. So more and more patients are doing amyloid PET. And as of about a year and a half ago, Medicare is now routinely paying for amyloid PET to be done, primarily because we have these new interventions that are required to these new medications that are, and it's required to get biomarkers. So, that's a really important point, that every patient that undergoes an evaluation for consideration of these new therapies, if they're in the appropriate clinical stage, should undergo confirmatory testing to confirm that they have abnormal amyloid pathology in their brain. The newest biomarker is a biomarker called p-tau217. This is a plasma-based test, so a blood test that is very reflective of amyloid pathology in the brain. And this is becoming routinely used in clinical practice really over the past 6 months to a year. We're doing this more and more, and it's a very easy test to do. So becoming a really routine part of what we do is drawing blood to look for amyloid pathology. I see this as a really, this is the up and coming area, and how we integrate this into clinical care and screening is something of active interest and not debate, but an active area of trying to figure out as a healthcare system how we implement the use of these tests in clinical practice. But p-tau217 is a very exciting development, and more of these biomarkers will come that may be reflective of different stages of the disease. So let's talk a little bit about therapies for Alzheimer's disease. So, what is a disease-modifying therapy? What is a symptomatic therapy? So about 30 years ago, the first symptomatic therapy for Alzheimer's disease was developed. These were the cholinesterase inhibitors, for which donepezil or Aricept is sort of the prototypical medication. So in the yellow line here is the progression of Alzheimer's disease. It is a slowly progressive disease that reduces cognition, function, and quality of life over many years. The symptomatic medications are in red here. And what they do is they boost people a little bit. You get a little bit better memory, but it doesn't change the trajectory. The slope stays the same. It optimizes brain function as much as possible. The effects are modest. About half of patients don't notice much benefit. About half of patients notice some mild, modest kind of improved memory or attention. It's worth trying. They're very low risk medications, but they don't slow the progression of the disease. They just boost people. The advance is the blue line. And this is what we're going to be talking about today: lecanemab and donanemab. These are therapies that clear amyloid from the brain. They don't make anybody better, but they do slow the progression of the disease. They change the rate of progression over time, and therefore they're thought to be disease modifying. They're clearing that abnormal pathology, and they're slowing the rate of progression. Ideally, we would have the green line where ideally we'd be curing the disease, which would be going up. Even better, a second step would be stopping progression. We're not there yet, but we do slow the rate of progression with these new therapies. And so, as I said before, these therapies, there's two of them. There's lecanemab and donanemab, approved in July of 23 and July of 24. The overall rates are about a 30% slowing of the disease. I'm going to show you the data from the primary papers next. But thinking that number is around 30%. And the goal of treatment is to keep people in an earlier stage for a longer period of time. And this is why we're really gearing these medications, or these medications are indicated in this early stage mild cognitive impairment to mild dementia. Once the disease progresses, first of all, there's less quality of life of the patient, and so slowing it down is less meaningful. And also the contribution of amyloid pathology to disease progression goes down. So one of the key messages here is that early diagnosis matters for planning purposes, but also thinking about therapies that can keep patients in an earlier stage for a longer period of time. These medicines are complex. I would argue probably some of the most complex medications that we give in neurology, and then we're giving it to patients that have memory problems. It requires a really committed physician and system of infusion centers, which I haven't talked about how they're given, but they're IV medications. It requires physicians' offices coordinating with infusion centers, radiology for monitoring. So again, these are not easy medications to give, but I do think hearing about them and understanding what's involved, I think again, opening the door, and then patients can make the decision for themselves. So that's what I said there, is that really here to increase awareness so that patients and families can make the appropriate decisions. Here's the data. Very similar to the stylized graph I showed. This is from these two well-done clinical trials, around 1,800 people or so in each clinical trial. Half of patients got drug, half of patients got placebo. In blue here on both lines, you can see the placebo rate of decline. There's a steeper rate in lecanemab, which goes by the brand name of Leqembi. You can see a slowing of the rate of decline. And very similarly in donanemab, you see this slowing rate of decline. The efficacy between these two medications is pretty similar. I could go into different details there about patient selection and things, but I think that's not necessary at this time. The efficacy is largely similar between these two medications, where they slow the rate of decline over time. What does that mean for somebody, a 30% or 27, 29% slowing of the rate of decline? It's really hard to conceptualize from some of these scales. The scales are designed for clinical trials, not necessarily for clinical practice. This data, I think, speaks towards that. So the trial recruited patients either in the mild cognitive impairment or mild dementia stage of disease. One way we can look at the efficacy of these medications is what is the rate of conversion from one stage to the next? So if you entered in mild cognitive impairment, what's your rate of converting to a mild dementia stage over this 1.5 year long clinical trial? That's what's shown here. Both lecanemab and donanemab reduce the risk of converting to the next stage of disease by about 35%. To put that into context, if you entered in the clinical trial in mild cognitive impairment, that's the mild memory symptoms that you're able to adapt around. If you convert to a mild dementia stage, that means that you now have memory symptoms that interfere with your daily functioning, where you now are reliant on somebody to manage medications or finances or drive. So if we're reducing that risk of progression by 35%, that means we're keeping people in these earlier stages longer with less functional and cognitive declines. So for me, that is very meaningful to patients. And other secondary measures also show that both patients and caregivers in these clinical trials, when they were treated with the medication, in a blinded way, so they didn't even know they were on the medication, report less declines in quality of life and of both the patient and the care partner. So I think I should have said this before, but one of the major issues with this disease is that it affects a patient's brain, but has really significant impact on the family, the spouse, the child. I mean, Susan shared her story already, that of her own father, a lot of impact on her life in being the caregiver for her father. She relied on Kensington, but to help, but still has significant impact on her father's and his life and the whole family. And so if we can reduce the progression of this disease, it not only improves the patient's quality of life, but it has significant benefit to the family. Again, nobody's getting better, right? The goal here, I'm not trying to sell that people do not feel better, people do not get better, but they do slow the progression in early stage disease. We're starting to get data now from 3 years. So this is lecanemab data. The story here is that, there's a little bit complicated data to go into details, but the effects continue at 3 years. So if you looked at after 1.5 years, people always talk about time saved, right? How much time does this medication give me? If you look at 1.5 years after this is the original clinical trial, it's about a little less than 6 months time saved. So this is the treated group. This is the placebo group. You draw a line back that the treated group is where the placebo group was at about 12 months. Okay, so you've had about 6 months of time saved. That's also that 30%. It's a little less, but sort of roughly. Then after 3 years, this is that treated group that stayed on treatment, and you draw back to this red line, which is it's not quite a placebo, but it's a historical control group. That amount of time saved is about 27 months, right? So the difference there is about 9 months. So that you went from 6 months to, sorry, about nearly 10 months. So you're continuing to see divergence from the placebo. So the longer patients are on it, the more time saved that this 30% is largely holding over the clinical trial. So that's encouraging that we're not just seeing some mild change, but that this divergence from placebo continues to hold even after 3 years of treatment. This data is to really emphasize the importance of earlier intervention. When we look at patients that come in at the earliest stages in this clinical trial, we see even greater benefit, both in the lecanemab-treated patients as well as the donanemab-treated patients, where in the earliest stages of the disease with the least pathological burden and the least cognitive changes, we're seeing up to a 60% slowing. So this is very exciting and an area, I think, of active research, which is that the earlier we intervene in patients, the more likely we are to see benefit. And then if we wait too long to clear this abnormal pathology, secondary factors, tau factors, and inflammation really takes off and results in an ongoing disease, a progressive disease that we can't modify at this time. I think new therapies will come that will help that later stage of disease. But I want to really emphasize the importance of early diagnosis and early intervention to maximize the benefit of these therapies. One analogy that I often use with patients when thinking about the contributions of amyloid and tau towards Alzheimer's disease is you think of amyloid as a fuel. So if you think of a forest fire, you need both the fire, but you also need the fuel. Amyloid is the fuel. It kind of primes the pump. Tau is the fire. In an early fire, you can clear the fuel and you may stop the fire. Once that fire really takes off, clearing the fuel is not going to change all that much. You don't clear the brush in the middle of a forest fire. So we want to clear that brain earlier to prevent the fire from taking off. This is to prove that the medicine does what it's intended to. We do see patients clear amyloid from the brain. We can measure that. There's a difference, though, between measuring the clearance of amyloid and the clinical efficacy, but these are very potent medications that remove amyloid from the brain. You see in orange here this dramatic reduction in amyloid by a few months of treatment, and you're starting to see it plateau because the majority of patients at the end of this year and a half of treatment have no detectable amyloid in their brain. Donanemab is a little bit more of a potent amyloid clearance than lecanemab, but you do see significant reductions in amyloid over time. This highlights that 80% of patients at the end of the trial were cleared with donanemab, as opposed to about 70%, a little under 70% for lecanemab. Now let's get into the complications. So that's the reasons, though I want to recap here. I talked a little bit about early Alzheimer's disease. How do we define the stages of the disease? How do we define and diagnose the disease? The importance of early diagnosis, and that we have these medicines that can slow the progression of early stage disease by about 30% and keep people in an earlier stage longer. How do we give these medications? They are antibodies, which means that they have to be given intravenously, IV. So patients have to go to an infusion center, sometimes in a hospital, sometimes in a clinic, and get an IV placed and receive it every 2 weeks for lecanemab, every 4 weeks for donanemab. There are some significant side effects that we have to be monitoring for. This medications can lead to a swelling or a bleeding that happens in the brain. It's called ARIA. The majority of patients are asymptomatic, and so we have to do really careful monitoring of patients while they are initiating this therapy, because the ARIA happens in that first 6 months of treatment. And so there is very strict protocols for monitoring patients. Lecanemab requires 3 MRIs in the first 6 months of treatment, while donanemab, the risk of ARIA is higher. You get it, it's less frequent, but the risk of ARIA is likely a little bit higher. So it requires 4 MRIs in the first 6 months of treatment. These medicines can be combined with other symptomatic medications like donepezil, Aricept, rivastigmine, memantine. Um, Medicare and insurance are covering it. Also, sometimes obviously it can require authorizations and things, which uh, is a source of frustration for many doctors' offices like myself. Um, and we are generally not giving these medications to people on blood thinners like warfarin, Eliquis, apixaban, rivaroxaban, because of that increased risk of bleeding. We don't want to be having people on blood thinners that then get a bleed, can lead to bad outcomes and really significant permanent disability. The other main precaution is that this side effect of ARIA can look like a stroke. In a very rare, less than 1% of people, it looks like a stroke, or they had a seizure and it looks like a stroke. And so patients have ended up in the emergency room and received medicines that break up blood clots um, because they thought they was having a stroke, and has resulted in really bad outcomes for patients. And so when patients are on these therapies, lecanemab or donanemab, they should not receive any medications to break up blood clots. And that's a pretty significant warning for patients to be aware of, and families to be aware of. No medications to break up blood clots. This is a summary of the medications kind of side by side. They both remove amyloid from the brain. There's some slight differences in how they do that. Roughly very similar efficacy. One is every 4 weeks IV, that's donanemab. One is every 2 weeks, that's lecanemab. And the rates of ARIA are higher in donanemab than which is the every 4 week medication, lower in lecanemab. My take on ARIA is that it is a manageable side effect. I mean, certainly patients and families need to be counseled about it. We have the ability to monitor and treat it if it were to arise, and the vast majority of patients don't get it, and even those that get it recover. The likelihood of resulting in a permanent disability or permanent problem because of ARIA is very low. I'm not trying to minimize it. I'm trying to put it into the appropriate context. Again, I think ARIA in my experience in treating patients, both in clinical trials and in clinical practice, has been that ARIA is a manageable side effect, particularly with providers that have a well sort of set up system to make sure that there's good communication with their hospital, their radiologists, their infusion centers. We can deliver this medication safely to patients. Again, not everybody needs to go on this medication, even if they're in the right stage, but I do think that it is a manageable side effect as long as patients are willing to undergo all of the required monitoring. Now, I want to leave time for questions. I've gone through this very quickly, so hope we can go back when you guys have questions. Where's the future of this disease? I think there's a few areas that are the future. I think developing therapies that address other aspects of Alzheimer's disease are critical. So we are currently, we as a field are working on developing medications to address the tau pathology in the brain. I think as with many things in medicine, multimodal treatment is better. Very frequently people are on multiple medications for blood pressure. They're on multiple diabetes medications. They're maybe on multiple cancer treatments. You don't just take one chemotherapy, you take a cocktail. And that's probably where we're going to be moving in Alzheimer's disease. The other thing with these new therapies, the amyloid therapies, is moving it earlier. Right now, we're treating people that have symptoms of the disease, but we actually have the ability to diagnose that pathology before patients even develop symptoms. And so I'm excited by this. I think we're getting some significant advances where we're going to be treating patients in these preclinical diseases. I do not advocate for that under clinical use, but we are currently doing 2 clinical trials to test people to see if they have this amyloid pathology but not have any symptoms, clear that pathology from the brain, and see if this results in longer time without the development of symptoms. So this is almost a prevention trial, which is really, really exciting. If anyone wants to get screened for this, please send us an email at brainhealth.sutterhealth.org. and we'd be happy. It's a blood test that you would be screened for to see if you have this pathology in your brain, and then you would be eligible to continue on in this clinical trial. So again, we're screening lots of people, so we'd be happy to screen anyone over the age of 65. One other trial that we're doing, this is for end-stage disease, is a brain donation study. Patients undergo a tau PET scan. Again, we want to improve diagnostics. So we are doing a brain donation study to see if patients that can undergo a tau PET scan while they're alive and then donate their brain to the trial to see if the scan lines up with the what we see on the pathology of the brain. This is very helpful, not because we're going to be scanning people at the end of life, but to prove that that scan works. And then hopefully we'll be able to implement that in earlier disease to better help with the diagnostic process. So if anyone that's in that, you have to have a mortality of less than 1 year, presumed less than 1 year. If anyone's in a later stage of disease with dementia or not, happy to have you screened for this trial. Again, send an email to brainhealth@sutterhealth.org. The last 5 minutes or so, I wanted to talk about risk factor modification. This actually occurs throughout life. This is data. This figure comes out of a consensus review paper put out by Livingston et al. That it's called the Lancet Commission. So the Lancet is a journal medical journal that has commissioned a group to really look at what are the factors throughout life that contribute to cognitive impairment in later life. It starts with early life. In early life, it's about education. So, people that have higher education this is protective for late life cognitive impairment. Going into midlife, you can see all of these things lined up. A lot of cognitive impairment is driven by vascular risk. So for many years, we've all heard about high cholesterol, physical inactivity, diabetes, smoking, high blood pressure, obesity as prevention of heart disease. That is certainly true, but it is also preventing and reducing the risk of cognitive impairment later in life. So what is good for the heart is good for the brain. Same things. And so I think it's really, really important to have good control of blood pressure and good control of these, particularly blood pressure, but good control of all of these vascular risk factors for reducing your risk of both heart disease, but also cognitive disease later in life. The goal blood pressure for the majority of people should be that top number, systolic, less than 130. Getting the LDL closer to 100, a little less data on the exact target, but probably under 100 is more ideal. If you've had other vascular risk, even lower is important. Later in life, social isolation, vision loss, hearing loss, these things really contribute to cognitive impairment. And the staggering number is that 45% of cognitive impairment and dementia is potentially modifiable. This is, independent of underlying medications that we give to people. So prevention is always better than treatment. If you don't get the disease, that makes us even, we're better. That's even better. So again, major point here is that dementia is modifiable, and treatment of vascular risk, particularly in midlife, is very beneficial for, it doesn't prevent, but reduces the risk of cognitive impairment. Everybody always asks about nutrition and diet. There's a diet called the MIND diet, M-I-N-D, well named. It's really a Mediterranean-based diet. Again, what is good for your heart is good for your brain. So higher in fruits and vegetables, leaner meats, whole grains, avoiding the saturated fats and red meats. It doesn't mean you can't have a hamburger, just don't have it all the time. And so these are some places for people to look. Again, you don't have to be I think focusing on a heart healthy diet and all the things that have been around for heart health really is brain health. The last thing I'll mention, the supplements, the brain health supplements, they are well marketed and completely ineffective. So they're expensive, avoid them, they're useless. I think I have throw them in the garbage. Don't spend your money. If you're going to do anything, spend money on buying more nutritious, fresh produce and spend money on nutrition, I would avoid all of these supplements. And frankly, I think a lot of them take economic advantage of people. So that's the end I had. I know I went really quickly because I want to leave some time for questions. This is my name, Armen Moughamian. You can email me at brainhealth@centerhealth.org. I'm part of the Ray Dolby Brain Health Center, where we have a group of physicians and social workers and neuropsychologists, all sort of geared towards treatment of patients with a variety of different degenerative brain diseases.
Thank you so much. So appreciative. And it's interesting. One of the questions that came in from registration was, what about octopus chemicals and other supplements? I think you have your answer. Your answer.
I mean, yeah, I avoid. There's no good data to support that any of these things work. If people feel a little bit better and it's not expensive, I mean, I guess it's okay to try, but generally I would avoid it. I just think that these things are very well marketed. And really completely ineffective. So my recommendation is a no.
I would agree 100% with you. And if they can afford all of the marketing and advertising and social media exposure they're doing, they're clearly making some money. Yeah. However, that's not bad, but I would agree with you on the supplement thing. I just want to emphasize what we just spoke about with the modifiable risk factors, because I did an interview with Dan Gibbs, who is a neurologist in Oregon, who actually wrote a book, Tattoo on My Brain. He's a neurologist, and he diagnosed himself with Alzheimer's. He has Alzheimer's disease. And he went full bore into the mind diet, the exercise, the sleep, the meditation, the sociability, and all the things of the 7 factors that are modifiable that you can do something about. And he is 100% convinced and sure that it has slowed the progression of his disease. So
I see it every day. And actually, he underwent this is public knowledge from his book. He underwent some of these treatments. He had a pretty significant side effect of ARIA. I absolutely agree. When I talk about treatment of this disease, maybe I should have said this already, I think about 3 buckets on an equal playing field. There's these new disease-modifying therapies, lecanemab and donanemab. There's the symptomatic medications, both for cognition, but also behavior, because certain behaviors can come up, and we have medications that can help soften some of these behaviors without being overly sedating. That can be a little bit tricky, but we have medications to address some of the symptoms that arise. And then there's that very large bucket of non-medication interventions that really do optimize function. And one of the other aspects that is just really having a very good routine is critically important for patients with cognitive impairment. It lessens the memory symptoms, lessens reliance on memory symptoms. So keeping a good routine of physical activity, social engagement, cognitive engagement is incredibly beneficial for patients with and actually without cognitive impairment as well.
So let's say for the audience today, they think, oh goodness, I think my mother, my husband, my brother, my father has MCI. What next?
I would start by going to their hopefully trusted physician or a primary care doctor and bringing up the concern. I'll be honest, I think that patients need awareness about, patients and family members need better awareness around early stages of cognitive impairment. I think primary care can do a better job as well. They're learning, but I think many primary care doctors do an amazing job of screening. They may do a brief assessment and may do some lab work, may order an imaging test, and often a referral to sort of depends on where you are in the country, often neurology, but sometimes psychiatry, sometimes geriatrics for additional evaluation. And I think that's a good starting point. A review of medications that they're taking, making sure that they're not on sedating medications, Benadryl, benzodiazepines. These can really exacerbate or even cause cognitive symptoms. So that's, I think, your starting point is the doctors you already know. If you feel that something is wrong and that you didn't get the evaluation that you felt satisfied with, there's no problem in really advocating for yourself. This can be challenging, but don't give up if you feel that you got dismissed and they're like, oh, I have those word finding difficulties too, not a big deal, or oh, I forget my keys every once in a while too. I don't think that's a really good answer from a primary care doctor. Patients do deserve to get at least a baseline evaluation with some level of objective cognitive assessment, an MRI or an imaging scan. And sometimes often in medicine, the squeaky wheel gets addressed. So it's okay to advocate for your family member.
I found it really helpful when I went to all these doctor's appointments with my father is I would take notes throughout the day because you think you're going to remember everything when you're in there, like what behaviors you're talking about. I just had a notepad in the kitchen, and every time I witnessed something, I took notes, and it was very helpful.
I think that's a great thing because you're gonna show up my office and I'll be like, "What are you worried about?" And everyone's like, "Ooh, something's different." And I mean, that tells you a lot by just saying that something's different. But the more concrete examples we have, the harder the better it is, and to get an evaluation, and the harder it is to ignore.
Okay, we have a bunch of questions, so I'm just gonna start at the top here. What about a person that has other medical conditions? Is that taken into account, like colitis, diabetes, arthritis, heart, when you're looking at these particular
Yeah,
studies?
with these new medications, it's a great point, right? These often in clinical trials, we do a cherry pick, the cream, the most healthiest people. These trials did a very good job of including people with vascular risk, high blood pressure, diabetes was included in these trials. So I don't have a lot of concern about patients that have those underlying comorbidities as long as they're well controlled. I think that we also have to put this disease into context. Alzheimer's disease is a significant disease, but it's a slowly progressive disease. And so if patients have other medical comorbidities that are impacting their overall prognosis, they have a cancer, for example, that is going to be limiting their life. I don't think these medications are really the most appropriate thing because they may not live long enough to reap the benefit. So why take on the risk of the medications, the inconvenience of all of this if you're not going to reap the benefit? So I think comorbidities matter in understanding the totality of the patient and the prognosis.
Yes. And Lori has a question. How do you know which therapy to give a person?
I think it's options are good, right? So a few things. One, the fact that we now have two medicines reinforces the efficacy, right? You have two medications done in two separate trials that show similar results. That really means that these things are doing what we think they do. It's not some statistical aberration. So I think one, options is good. It reinforces the science. When I offer both medications to patients, I don't have a strong preference for one versus the other. I think the efficacy is very similar. Where you're making your decision is on the safety versus inconvenience. So every 4 weeks is half as frequent as every 2 weeks, but you do take on a higher risk of ARIA. One thing I didn't talk about today is this gene called the ApoE gene. It helps risk stratify for the risk of ARIA, and that can be helpful. If you're in the lowest risk group for ARIA, you may take the convenience of the less frequent infusions with the higher risk because your risk is relatively low to begin with. If you're in the higher risk group, you may turn more towards the lower risk medication and the more frequent evaluations. If you're driving an hour and a half each way to an infusion center, that's a pretty big commitment. You may take the less frequent infusions for that convenience of not having to go in as frequently. So that's a really nuanced conversation, but I couch it in this safety versus convenience and that underlying personality of the patient towards where do they settle in that conversation.
That's a great answer. I was thinking the same thing. Why wouldn't I just do donanemab? So
yeah, well, that's your personal preference. Well, some people are like, I want the least risk possible. I'll do the lower risk medication. So again, options I think are good for everyone.
Yes. And I love this question. If these treatments remove amyloids, what causes the advancement? Why not just stop?
That is because Alzheimer's disease is not just due to amyloid, right? Okay. So it's due to amyloid, particularly in the early stages. But as the disease progresses, you get more of that tau protein. And so once the tau starts to take off, the amyloid contribution goes down. And so that's why we still see progression despite amyloid being gone from the brain. It's the effects of tau. So
Mm.
this is again emphasizes the importance of earlier interventions. If we can capture people before they have a lot of tau, remove the amyloid, maybe we can really prevent that tau from taking off and the advancement of the disease.
Well, I think you've convinced me. I know you asked me to participate in that trial, and I think
I ask everybody because I think
I'm
it's
all,
really exciting.
I'm all in now, but I really am because the blood test is so promising, right? And that just detects if you're a candidate for this trial. So I might go in, get my blood drawn, and you might call me and say, we can't have you. And then I go, woo-hoo. But
Yeah, it's a negative screening for this trial can be very reassuring. And
yeah,
actually, a recent study from the Alzheimer's Association, like a week or two ago, came out. People want to know. I think there's always this concern and sort of patriarchal medicine attitude, like, do you really want to know? The reality is that we have the tools and people want to know, just like cancer, right? Obviously, you want everything to be negative, right? You go in for a mammogram not because you're hoping you're going to get a mass, but you do it for the reassurance and because you know that early detection matters. And so this is no different than anything else in medicine. The earlier we intervene, the more likely we are to see benefit. We treat blood pressure because we're preventing heart attacks, stroke, and cognitive impairment, not because we care exactly like you're getting to normal blood pressure. We're trying to prevent those later stages of damage to organs.
so really the blood test is the way to start, not an MRI.
I mean, they do different things, right? So again, not every cognitive impairment is due to Alzheimer's disease. So the MRI is asking in a much broader sense: is there a structural change in the brain, a stroke, a tumor, some other structural lesion that can contribute to cognitive impairment? So I think that is important. They're parallel, but asking different questions. That blood test it asks a very specific question of whether there's Alzheimer's pathology in the brain or not. It doesn't address non-Alzheimer's type causes, which is anywhere from 20 to 30% of cognitive impairment.
And then, we talk about sleep being so important. Robert asked a question. How important is deep sleep on tau and cognitive impairment? And number two, they have those sleep rings that you can monitor
Yeah.
your, you can actually do it on, I think, an iPhone or whatever. But
Yeah, the Aura Ring. Yeah, a lot of people have these things now. I am not quite sure how good those rings are. I would love to see somebody that went under a traditional sleep study and the Aura Ring and how much they correlate. I don't have the ability to do that. They're probably internally consistent, right? So let's say you get one and it says you do terrible sleep, but then you work on sleep hygiene, you fall asleep at the same time, you're feeling more rested, and it shows your sleep number improve. I think that's a positive reinforcement. I like to ask people how you feel in the morning. If you feel rested, you probably slept pretty well. If you don't feel rested, maybe we need to figure things out. But his question is a very good one. That sleep disruptions in sleep do contribute to cognitive impairment. Sleep is restorative for the brain. Getting good sleep will only improve cognition. This is true for people that don't have cognitive impairment. If I don't sleep well, I'm not running on all cylinders. Patients with an underlying cognitive impairment and degenerative disease are even more vulnerable to that. He alluded to this question about tau and sleep. There have been some data in really small studies saying that sleep is helping to clear proteins from the brain, like tau. I think we're in the early stages here, but of like the exact relationship between sleep and brain homeostasis. But there's, I think, very little question that better sleep is better for cognition. So being routine around your sleep, trying to find interventions, not always medicines, but just simple things like turning the lights off or dimming the lights before you want to go to bed, less screen time, turning the TV off, being routine as possible around sleep, so that you can get the best quality of sleep. Addressing obstructive sleep apnea, if present, can improve your quality of sleep and your overall brain health. Same with regulation of mood. These things are important.
and Debbie and Christine are asking about hereditary risk factors.
Yeah, so the genetics of Alzheimer's disease are there's sort of two buckets. There is the genes that cause the disease. These are incredibly rare, like very, very, very rare. Almost always happen before the age of 65. Very rarely are we even testing for those unless people have an onset in early onset before the age of 65. Those are like get the gene, get the disease. All right. Very, very rare, not something routinely tested. There are risk factor genes for which the ApoE gene test is the most common. And this increases the risk for developing the disease. In an asymptomatic individual, I think it is really a useless test right now because it's in around 20% of the population and accounts for about 50% of Alzheimer's disease. So, okay, that does increase your risk, but that means that half of people don't have the gene and still get the disease. So I think it can, one, falsely increase your anxiety, like, oh God, I got the gene, I'm definitely going to get the disease, because that's not true. Or two, it can also give you false reassurance, like, oh, I don't have the gene, therefore I'm not going to get the disease. So I don't use it in that state. That's like 23andMe. It doesn't even 23andMe doesn't exist anymore, but that's what they used to test for. I don't really recommend that. I would recommend, regardless, that you should live that brain healthy lifestyle. The use of the ApoE gene test has increased, though, because of these amyloid therapies, where it helps to risk stratify whether people are in low, medium, or high risk for the disease. So I have been using it, but I don't use it in asymptomatic individuals. I just don't find it helpful.
Great. And then last question, and I just want to thank everybody so much, but real quick, last question about the use of light and sound therapy on reducing p-tau at MIT.
Yeah, so this came out of some preclinical data where, we know in Alzheimer's disease, if you put an EEG on somebody's brain and measure their brain waves, they are disrupted. And so somebody at MIT used some fancy techniques to try to entrain the brain to have normal rhythms. So one way to do that is to give sensory stimulation at a specific rhythm. So they use light and they use sound to try to entrain this gamma rhythm in the brain, which is deficient in people with Alzheimer's disease. They did that in mice, and it seemed to work. Now, mice are not don't have Alzheimer's disease; they have these models. There are early stage trials that right now are very, very small that are maybe showing some promise. I think it's an exciting area of probably low risk intervention that may be beneficial. It's too early to recommend that to patients. I think we have to be guided by the data. If patients are super motivated to participate in one of these types of things, I would do it in the setting of a clinical trial where we can really demonstrate the safety and the efficacy of these types of interventions. I think the multimodal interventions are the future. Figuring out what they are is going to be important. And we want to make sure also that we're guided by the evidence. We don't want to be just like the supplement stuff. We don't want to be doing a lot of things that don't provide benefit.
And I will say in the Q&A, there was a lot of comments about your analogies, your presentation, and really the hope for for those of us that have walked through with our parents or our spouses or sometimes our children that have early onset Alzheimer's that I have met. It's so devastating, but these things are so promising, and I just can't thank you enough for your dedication to it.
And I get, I want to also, ideally, we're capturing patients in the earliest stages where we can offer different therapies, whether they go on or not. I am a firm believer that this is a manageable disease. It's in many ways a terrible disease, but it's a manageable disease regardless of the stage. And so, don't lose hope. There's a lot of things that can be done using different medications and different non-medication ways to really optimize the quality of life of the patient and the family that are dealing with this disease. So I really do believe that.
And a lot of people asked for your email, brainhealth@sutterhealth.org, but I just want to reiterate that you'll all receive a copy of this presentation to share with friends and family. Happy. And if they wanted to participate in your trial, the blood trial, would they be able to do that other places throughout the country? Someone else?
Yeah, it's done throughout the trial. There's a couple of trials that are going on. There's the Trailblazer, which is closed, and the AHEAD trial, which is closed. But the one that's recruiting right now is the Trail Runner. It's run by Eli Lilly. There are sites throughout the country that are doing it. It's called Trail Runner. I would encourage people. Right now, it's over the age of 65 can do the blood screening. I think this is a really promising trial. Obviously, we're waiting for the data, but I'm excited by this trial. So yeah, it's throughout the country. I don't know if every state, but it is a multi-site trial, and you should be able to find that Trail Runner trial website online.
I'm just going to do one more plug. We donated my father's brain to Stanford, and it's so important to do that so that people can really research the causes and what's going on in the brain. It's hard to do that when they're alive. But anyway, thank you so much, and good evening if you're on the East Coast, and good afternoon if you're on the beautiful West Coast. We're finally having some nice weather. And thank you so much. We are just grateful. And Kensington Senior Living, thank you as well.